Thank you for joining us for OrthoAlliance's OrthoInsights educational webinar series on sports medicine. Tonight's speakers are Drs. Aaron Baessler, Jordan Bonier, Nicholas Walla, and Eric Erb. Tonight's topics include common sports injuries of the elbow, shoulder, hip, and knee. Speakers will answer questions after the final presentation. Please type your questions in the Q&A box at the bottom of your screen. We will include all question and answers on our OrthoInsights blog located on the OrthoAlliance website at orthoalliance.com. Our first speaker of the evening is Dr. Aaron Baessler, orthopedic shoulder and elbow surgeon from Central Indiana Orthopedics. Dr. Baessler will be speaking on common sports-related elbow injuries. Dr. Baessler?
Sure. All right, I'm Dr. Aaron Baessler. I'm a shoulder and elbow surgeon at Central Indiana Orthopedics. I'm going to be talking a little bit about common elbows and common injuries in sport to the elbow specifically. This is not encompassing of every injury, but it's more common ones that I see in my practice and more common overall. Goals of this talk, we're going to talk about the common injuries, discuss treatment for each injury, and discuss expected recovery and goals to return to sport. The most common by far injury is called lateral epicondylitis or tennis elbow. This is extremely common. It's probably the most common thing I see in my practice. It's caused by injury to the outside of the elbow here, to the tendons, the common extensor origin, and specifically there's one particular tendon called the extensor carpi radialis brevis that's always involved or almost always involved, where over time it degenerates, which is a fancy word of just saying it gets old. And oftentimes there's an injury that predisposes people to this, and it causes a small little tear in it, and it leads to an inflammatory response. This injury, even though it's very common, it does not require an extensive workup, such as an MRI. It's a clinical diagnosis. So if you have pain on the outside of your elbow, pain with gripping objects, picking things up, decreased grip strength, it's almost always tennis elbow. This occurs to almost everybody at some point in their life. Most commonly, it's in age 35 to 50, and adults annually, it affects up to 3%. It's usually in the dominant arm, but not always. And most of my patients actually do not play tennis. It's usually caused by something where they gripped something wrong and picked something up and felt something. To treat this, if you do nothing and just give it time, most of the time you'll get better. It can take a year or more for that to happen. So there are some things that we can do to help speed the process up. Stretching or home exercise program, in addition to some physical therapy, can help significantly. The use of a counterforce brace, which is a brace that goes on the elbow just below where it hurts, can take the tension off of that area and help it feel better. And then there are injections that we can do in the office, whether it's a steroid or platelet-rich plasma or PRP, that can often accelerate recovery and improve symptoms. I still do surgery sometimes, but it's for patients that just don't get better. And usually it's those that don't get better after a year or more. So a similar problem that's on the inside of the elbow, it's called medial epicondylitis or golfer's elbow. It's basically the same thing to the other side, where the flexor tendons on the inside of the elbow get overused, leading to a small micro tear in those. The pain is similar, but it's on the inside of the elbow. It is more common in golfers or people that throw or play racket sports, although you do not have to do those in particular. It can be associated with ulnar nerve symptoms or funny bone nerve symptoms, where you can get tingling or pain that shoots down the forearm into the small finger and ring finger. And the treatment is essentially the same as tennis elbow. I really won't go into it much more. Staying on the inside of the elbow, you can get injuries to your ulnar collateral ligament or UCL. So this picture on the left is an MRI image showing the inside of the elbow, and this black structure that looks like it's torn off. It's because it is. That's the ulnar collateral ligament. And this diagram on the right shows that it's a complex structure on the inside of the elbow, but most often we really care about this anterior band of it. The UCL is the primary stabilizer to valgus stress or preventing the elbow from bending inward. If people injure this, most often There's different ways you can injure it, but usually you feel a pop on the inside of the elbow and have immediate pain in that area. In throwers, they'll notice pain along with the loss of throwing velocity. And again, with this, you can have symptoms with your ulnar nerve, especially if it's getting stretched out. It can be grouped into two different categories. A traumatic tear is usually in people that are fighting or fall on their elbow where they feel a pop immediately without any preceding elbow pain. It can be associated with an elbow dislocation, or it can be grouped into an overuse injury. And this is typically in throwers where there's repetitive stretching and micro trauma of that ligament. And then all of a sudden, after a while, it can tear off. And usually that's a result of most often poor throwing mechanics. So you can see this diagram down here shows the phases of throwing. And most commonly, it's a problem in the late cocking or the acceleration phase. It's due to not enough rest in between throwing sessions. So people that pitch year round are often predisposed to this. Most patients can be treated without surgery for this problem, but that includes rest, and rest means rest. So in throwers, that means 6 weeks of no throwing. After that, you can start some physical therapy because your elbow will get stiff. And after it gets unstiff, you can strengthen it and progress back into a throwing program. And overall, this will take several months to get back to your sport. It is not a quick recovery. In athletes, the treatment's a little bit different, especially in throwers. These used to be career-ending injuries, but our surgical techniques and rehab protocols have gotten much better over time. You can repair the ligament. So you reattach the ligament to where it belongs, and that's usually reserved for younger athletes that have acute tears that are avulsion type, meaning it didn't tear in the middle, it tore off of the bone. It can happen in elbow dislocations, and this is typically not done in throwers. Instead, in throwers, we do a UCL reconstruction, which is a Tommy John surgery, which is some people know about. And to reconstruct it, typically you'll use a tendon either from your own body or from a cadaver. Using it from your own body is more common, and you use that to reconstruct the ligament. Return to sport after any of these surgeries, especially throwing, is not quick. It's at least 1 year, no matter what you do. Moving on, there are tears of the biceps and triceps. So the biceps itself, most people think that it's an elbow flexor, like you flex your arm and your bicep gets really strong. It is, but the major function of it is supinating the forearm or turning a key or a doorknob, that type of motion. The triceps is on the back of the arm, and it's primarily the only elbow extensor. So straightening your elbow out or doing an activity like pushing up out of a chair. You need both of these for most activities of daily living, unless you're elderly and you don't do much. Most commonly, these injuries occur in weightlifting type activities or when you go to pick up something or something happens that you're not expecting. And in general, at least in my practice, surgery is recommended for these problems. These occur primarily in men in their 40s. They're associated with steroid use, other systemic conditions. With distal biceps tears, often or pretty much every time, you'll feel a pop in the front of your elbow. It'll swell. You'll see a deformity there. If you do not treat this with surgery, you'll lose about 50% of supination or that strength to turn a doorknob or a key. And it's important that if this happens to you, you need to go see your physician right away because you have roughly a 4-week window to repair it. After that time, the tendon it's like a rubber band. It'll kind of shoot up your arm and you can't get it back down to where it belongs. For triceps tears, they're a little bit less common. Usually they occur in older people, although they can happen in younger people. And if you treat these without surgery, you will lose almost all the strength with elbow extension or straightening your elbow out. And that's a very important motion and very important strength because as you get older, you need your arms to push up out of a chair. In general, for either repair of both the biceps or a triceps, it's about a 6-month recovery back to normal. At least in my practice for a biceps, I keep you in a sling for 6 weeks. I start you in therapy early on just to get your motion back. Strengthening starts at 3 months, full recovery 6 months. With the triceps, it's pretty much similar, but I just put you in a different type of brace that controls your elbow motion. I alluded to this previously, but an elbow dislocation is where the joint dislocates, usually it comes out the back or posteriorly. It's usually due to falling onto an outstretched arm. You'll know it, you'll see it, you'll feel it. It can be grouped into simple or complex, simple being that there's no fracture or break involved, and complex being that there is a fracture involved. And in order for your elbow to dislocate, you have to tear or stretch out some ligaments. So the lateral ulnar collateral ligament, the one that's on the outside of the elbow, always tears. And the ulnar collateral ligament on the inside usually is torn, but not always. So if you have this happen, or you know anybody that has this happen, it needs to be reduced or put back in urgently, as quickly as possible. For those that are simple without a fracture, most of these do not need surgery. Typically, I'll splint them for about a week, and then I'll get them out of the splint and start early motion. The elbow will get very stiff, so therapy is very important for this. If you don't do therapy, your elbow will persistently stay stiff. Surgery is only indicated in the patients that even after doing all the therapy, their elbow is still unstable where it wants to dislocate. For those that are complex, that have a fracture, surgery is almost always indicated, and it should be done rather urgently within a couple weeks. To end this, I'm going to talk about some overuse injuries, and these are primarily in throwers. So valgus extension overload. This is a lot of words on this slide, but basically with repeated throwing, the back of your elbow, it's called the olecranon, starts to shear or rub up against the back of your arm or your humerus up here. And when doing that, it creates these bone spurs on the backside of your elbow. In addition, it'll stretch out the inside of the elbow so that ulnar collateral ligament will get stretched. And you'll also get compression on the outside of the elbow so you can develop arthritic changes on the outside. At first, and almost always, the treatment is non-operative. You stop throwing completely, you take time off, do some anti-inflammatories, and then progress in a throwing program. For people that persistently have symptoms despite doing that, there are surgical options, and that's typically going in with a scope and resecting or taking out those bone spurs and potentially doing something on the outside of the elbow. If you're having ulnar nerve symptoms or pain or tingling that shoots into your forearm, that can be addressed as well. Little league elbow is essentially the same thing as valgus extension overload, but it's in children or adolescents. And this particular injury occurs at the inside of the elbow where there's a growth plate that repetitively gets stretched out by the ulnar collateral ligament, and that can lead to a stress reaction and inflammatory response to that growth plate. Risk factors for this are kids that pitch year-round, which is more than 8 months of competitive pitching, if they pitch more than 80 pitches per game, and if they continue pitching despite having pain or loss of their throwing velocity. And again, the treatment for this is always non-operative. They have to stop throwing completely and progress in a throwing program. And this is one of the toughest things to treat, at least in my practice, because it's very hard to get an adolescent or a child to stop doing what they want to do because they want to be better. But the treatment is to stop throwing it's a short period of time. It's not that long in the grand scheme of things. And to end it, this is a relatively rare injury, but I do see it sometimes in throwers. You can get a stress fracture of your olecranon or the back part of your elbow. And again, it's related to continuing to pitch despite having pain, where you get this picture shows this little crack in the bone coming down. And this pain is particularly posterior or the backside of the elbow pain. It's worse with throwing and it improves when you rest. This injury does require either a CT or an MRI to diagnose. And again, this is a common theme, but a lot of these injuries, the treatment is non-operative, and this is complete rest for 6 to 12 weeks until the symptoms go away. Thank you. I will answer any of your questions later.
Thank you, Dr. Baessler. Next, we have Dr. Jordan Bonier, orthopedic surgeon at Orthopedic Associates of Zanesville. He will be speaking on common shoulder injuries in sport.
Thank you. Let me get my screen shared here. Okay, I'm Jordan Bonier, DO. I am a total joint, hip, and knee surgeon, and I also do general orthopedics, which involves shoulder. So we'll talk about some common injuries related to the shoulder in sport. So first one I'm going to talk about here is rotator cuff tears. So what is the rotator cuff? Rotator cuff is a group of four muscles and their tendons, and it stabilizes the ball and socket joint of the shoulder. So it allows for a very wide range of motion in the shoulder compared to other joints in our body. So this is one of the most common shoulder injuries in athletes, and typically it's going to involve sports that have repetitive overhead motions, typically baseball, with throwing athletes, tennis, swimming. So how does the injury occur? There's several different mechanisms. Acute injuries are typically more traumatic, and that's falling on an outstretched hand or falling directly onto the shoulder itself. The more common type of rotator cuff tear that I see in my practice is more chronic wear and tear over time. I refer to this as a degenerative rotator cuff tear. The symptoms associated with a rotator cuff tear are often pain, sometimes weakness, limited range of motion, particularly with raising the arm overhead, reaching behind the back. Patients will oftentimes describe difficulties with reaching up into a shelf or washing their hair, reaching behind their back to put on a bra strap. So those types of things are typically raise a red flag for potentially having a rotator cuff tear. So the treatment almost always starts with non-surgical treatment, particularly in those tears that are the more chronic wear and tear type tears. So, this is often effective for the partial tears. When we describe rotator cuff tears, we talk about partial tears versus full thickness tears, where the tendon is actually completely torn off of the bone. And those types of tears will typically present more with more profound weakness and oftentimes more pain. The partial tears, where only part of the fibers are torn off of the bone, and the less severe injuries oftentimes are more amenable to non-surgical treatment. So the mainstay of non-surgical treatment for rotator cuff tear is physical therapy, and that focuses on strengthening of the muscles that surround the shoulder and improving range of motion, anti-inflammatory medications to help with the pain, and then injections also to help with the pain. And typically these are cortisone injections, which is an anti-inflammatory medication as well. But sometimes we use other alternative types of injections. And typically in my practice, we do a fair amount of platelet-rich plasma, which is a regenerative type of biologic injection that has some good results with rotator cuff injuries. So that typically is the course of non-surgical treatment that we'll attempt for usually at a minimum of 4 to 6 weeks. In those cases where the tear is large, which we talked about, full thickness tear, the patient has profound weakness, or just non-surgical treatments aren't effective and they continue to struggle with pain and weakness, that's when we start to think about doing surgery for rotator cuff tears. And typically, rotator cuff tears are treated with repair of the torn tendon. So the tendon itself is brought back down to the bone, usually with anchors. And the anchors have sutures that are attached to them that we stitch the tendon back down to the bone. This can either be done arthroscopically, which is the way that I typically do it, through the use of a scope, where it's a more minimally invasive type of procedure where we make small incisions and put a camera into the joint and take a look around and diagnose the issue. And then through other small little incisions, we can take instruments and repair the tendon. Alternatively, it can be done with an open repair, which is a standard, more invasive incision if the tendon is a larger tear. Shoulder dislocation. So this is essentially the ball of the shoulder joint pops out of the shoulder socket. And so because the shoulder is the body's most mobile joint, it makes it more susceptible to dislocations than other joints in our body that are more of the hinge type joints, like the knee and the elbow. So because of its greater range of motion, it's more susceptible to dislocation. This type of injury is common in contact sports. So this will be, football, rugby, hockey, any of those types of sports that involve direct hits to the shoulder. And so that's typically how this occurs, is a sudden impact or fall, especially when the arm is in an awkward position. It can happen with falling on an outstretched arm. And the symptoms are usually an intense, immediate pain, a visible deformity. So you can visibly see that the ball does not look like it's located into the socket. And then a complete inability to move the shoulder. So this is typically treated immediately with what's called a reduction. So what that means is that a healthcare professional will manipulate the shoulder back into place. So it's literally taking the ball and pushing it back to where it belongs next to the socket. So usually this has to be done in a healthcare setting. So typically in an emergency department where medication can be administered to relax the shoulder muscles and allow for more ease and a safer reduction maneuver. But sometimes the shoulder will self-reduce when the athlete is on the field, or if the athlete's used to having recurrent dislocations, sometimes they can reduce the shoulder themselves. But typically this will be done in a healthcare setting. And then after reduction, after the shoulder's put back into place, a sling will be used for immobilization. The next step in treating a shoulder dislocation is rehabilitation. And really, this will focus on strengthening exercises to prevent future dislocations. And so typically that's done for about 4 to 6 weeks, sometimes longer, and with gradual return to motion. Surgery is sometimes indicated, and usually that's if the joint remains unstable. So if there is a recurrent dislocation, or if it's a first-time dislocator in a younger athlete, sometimes we will consider surgery. And typically when a shoulder dislocation happens, there can be damage to a structure called the labrum, which is a cartilage ring that surrounds the socket of the shoulder joint. And it somewhat acts like a bumper and increases the surface area of the joint. And so when the ball pops out of the socket, sometimes you can get damage to that labrum, and oftentimes damage even to the bone of the socket. So the surgical treatment is oftentimes directed at repairing this labrum or the bone and the labrum complex. Other type of stabilization procedures do exist to try and increase the stability of the shoulder in those people who do have recurrent dislocations. Last one we're going to talk about is shoulder impingement syndrome, and this is probably the most common type of shoulder issue that I see in my practice, whether related to sport or not related to sport. And essentially what this is the tendons of the rotator cuff become irritated and inflamed as they pass through a space that's called the subacromial space. So this is a small space where the rotator cuff tendons sit underneath a bone called the acromion, which is part of the shoulder blade. And if you touch the top of your shoulder and you feel the bony prominence, that's known as the acromion. And right beneath that are the rotator cuff tendons. So this will be common in sports with repetitive overhead activities such as swimming, tennis, volleyball, golf, those types of activities where the rotator cuff is brought into close contact with the acromion. So repetitive overhead motions cause the tendons to rub against the acromion, or this bone related to the shoulder blade, which leads to inflammation and pain. And so the symptoms typically will involve pain when lifting the arm, and particularly when reaching overhead. And sometimes in the case where we do start to see some more severe impingement syndrome, we can start to get some tears of the rotator cuff. And in those cases, that's when we'll start to see some weakness in the shoulder. So the treatment for this mainstay, just like the rotator cuff pathology, is non-surgical to begin. So typically this involves physical therapy, which is aimed at improving the shoulder mechanics. So we want to strengthen the muscles that surround the shoulder and the shoulder blade to try and improve the mechanics of the shoulder and prevent that chronic impingement that happens with overhead motions. Anti-inflammatory medications can be a great adjunct to try and reduce the pain that's associated with the inflammation in the tendons. And on the same regard, injections can help with that as well. And typically, as we were discussing with rotator cuff injuries, cortisone injections are the mainstay of treatment, which is an anti-inflammatory medication. But also in my practice, I do utilize biologic injections such as platelet-rich plasma. In those cases where symptoms persist despite non-surgical treatment, which really I like to see at least 6 weeks of non-surgical treatment before I consider doing surgery for this type of condition. But if these symptoms do persist, then you can consider surgery. And typically this is done, at least in my hands, with arthroscopic surgery, where we attempt to create more space for the rotator cuff tendons when you lift up the arm. So essentially what we're doing is focusing on trying to remove bone spurs that sit right above the rotator cuff and removing some of that inflammatory tissue that develops in what's known as the bursa, which is a little fluid-filled cushioning sac that sits between the bone and the tendons. And so you can go in there with a camera and take a look and diagnose the problem in the joint, and then take instruments through arthroscopic portal incisions, which are usually about 1 centimeter big, and clean out bone spurs and clean out the bursa inflammatory tissue to try and increase the space for the rotator cuff tendons. And this typically will resolve the problem. And there's a quicker return to activity and sport with this. Occasionally I see patients back after this type of surgery in 2 weeks. We take out their stitches in the office and they've got full range of motion and no pain. So this is typically a quicker recovery than a rotator cuff repair, which we're more looking at sometimes 3 to 6 months of recovery, depending on the size of the tear. Thank you.
Thank you, Dr. Bonier. Next, we have Dr. Nicholas Walla, JIS orthopedic surgeon. He will now discuss common sports-related hip injuries.
Good evening, everybody. Let me share my screen here. Right. So I'm Dr. Nick Walla, and tonight I will be talking about some hip injuries in sports. I'm an orthopedic doctor that's trained in sports medicine, which is a conglomerate of different issues, mainly all issues of the shoulders, elbow, hip preservation, such as hip arthroscopy, and as well as a lot of knee issues like ACL injuries, meniscal injuries. But tonight we'll be focusing my part of the discussion on hip injuries. A little background on the hip. It's close to the core of the body, so less injured than some of the other parts of the body when we're talking about sports injuries. Approximately about 6% or so of all sports injuries involve the hip. It's a very complex joint. There's numerous muscles, as well as bony anatomy that are playing an orchestra to create a well-functioning hip. And like anything in medicine, requires a systemic approach to making accurate diagnosis using history, physical examination, as well as a proper evaluation of different types of imaging. So the first topic regarding hips is one that we see pretty commonly in the sports medicine world, and it takes a little bit of a trained eye to appreciate it. But if you can see my cursor here on the left side, this is an X-ray of a pelvis, and this is a hip. The ball is here. There's a little bit of an overgrowth here where the cursor is, and it's a little aspherosity of the ball, and it can bump into the socket here, and that's what we call hip impingement. The medical terminology is a fancy word called femoral acetabular impingement, or FAI. It's pretty much the same thing as hip impingement. And what it is it's a dynamic issue that's caused by abnormal contact between the ball and the socket. And it's obviously a mechanical issue, so you get some overgrowth here. It's called a cam lesion. And you can also have overgrowth of the socket, which can cause that hip to impinge as you rotate it, flex it, and internally rotate it. And what that leads to is pain as well as decreased motion, particularly after higher impact activities such as sports. A little bit more insight into this. So the diagnosis of this um, is you have to have a thorough examination of the hip as well as appropriate imaging. And the treatment for it, we start conservatively, as you've heard. A lot of things in orthopedics, we try to, take care of the problem non-operatively, which would involve physical therapy, which would be in targeting flexibility of the hip, as well as some core strengthening, and then anti-inflammatory modalities like ibuprofen, Aleve. And then in this condition in particular, we'll do an intra-articular injection, which is usually a cortisone as well as a numbing agent. And typically we like to see, at least some temporary relief of the hip pain, which can be both diagnostic as well as potentially therapeutic and giving us information that the problem is within the hip. And then, if those modalities aren't providing enough relief, that's when we consider surgery like a hip arthroscopy. And if you look at the images here on the right side of the screen, the image where my cursor is at in the bottom here is the white part of this is the ball portion of your hip. And this area here is an area where the arthroscopic shaver actually shaved away some of the bone here, because that overgrowth of the bone can cause impingement along the socket, and it can damage your labrum as well as your cartilage over time. And if you look at the top image here, that labrum has been repaired with a couple sutures that are holding it back in there. The next common hip injury that we see involves the hamstring tendons. So there's different varieties of hamstring tears, and you'll definitely, everybody's heard about them. Majority of these issues, a hamstring strain or a tear, usually involve the muscle belly. So there's different muscles that are composed of the hamstring. It's a complex of muscles called the semitendinosus, semimembranosus, and the biceps femoris, which has a short and a long head to it. They're highlighted in this picture here. And it occurs during activities that involve sudden acceleration, deceleration, such as sprinting, jumping. You hear a lot of football players injuring this. And then, you can have more severe injuries in water skiers where they're suddenly jerked up from the water, when their hips flexed and their knees extended, puts the most force on this muscle group. And it can result in a lot of thigh pain as well as around the buttock region. And even in the severe cases, which is when the tendons actually tear off from part of the bone up top here, it can lead to some significant bruising, which is concerning, and you should definitely seek some evaluation if that occurs to you. So the diagnosis, physical examination, and then we will typically get an MRI if we're concerned about the tendon pulling off the bone, not so much for the muscle belly injuries. But again, we'll start for the most part with conservative management, especially for the muscle belly injuries, with rest, ice, physical therapy, working on some gradual stretching of the muscle group, and then eventual strengthening and returning back to play. When it's a single tendon pulled off the bone, we typically will rehab those conservatively, or if it's two tendons that aren't too far off the bone, less than 2 centimeters, then we'll typically treat it non-operatively, and then pretty much all muscle belly injuries. And then the surgical issues is when a couple of the tendons pull far away from the bones, greater than 2 centimeters, or if you have a full 3 tendon pull off the bone, that's something that we try to have just do surgery to repair those tendons back to the bone, in an expedited fashion within a couple weeks or so. So it's important to seek evaluation if you ever have an injury like this. The third kind of most common hip injury is a conglomerate, commonly referred to as a sports hernia. And it's a bit of a misnomer because typically does not involve a hernia, but what it is an imbalance really of a couple different muscle groups. Your core muscles, one of them is called your rectus abdominis, and that attaches to your pelvis bone, as well as some of the muscles that pull your thigh inward, called your adductors. And really what's going on here is extreme amount of force going on that, or an eccentric force that's pulling those in different directions. And this injury is typically involved in kickers, so soccer players, as well as hockey players. With the stride that they have, they put some tension on their adductor muscles as they fully lengthen their stride. And then in football, you see it sometimes, but it's mainly, you see it more in the place kickers, maybe even the punchers. And it results in pain along your lower abdomen as well as the inner thigh. This diagnosis typically made with physical examination, imaging. Typically, we'll definitely start with some conservative management, rest, ice, anti-inflammatories, some physical therapy targeting at strengthening the core out, as well as the hip muscles. And then you can try different injections around the muscles that are injured, especially if you're in the midst of a sports season and you want to finish it out. And then surgery is really considered after failed management of these conservative options. So I'd like to see probably about 3 months or so of conservative management. And with that, if that fails, however, the surgery can be considered. And typically what you do is you repair that abdominal muscle back to the pelvis, or you can potentially lengthen your adductor muscle out and give it some relief of these muscle imbalances that are pulling against each other.
Thank you, Dr. Walla. Our final speaker of the night is Dr. Eric Erb, orthopedic surgeon from Orthopedic Specialists in Sports Medicine. He will be discussing knee injuries in sports. Dr. Erb?
Thank you very much. Let me get my screen pulled up. Okay, so my name is Eric Erb. I did my medical school and residency in Dayton, Ohio at Wright State, and my fellowship in adult reconstruction at Mississippi Sports Medicine in Jackson, Mississippi. Currently employed at Orthopedic Specialists in Sports Medicine in Granville, Ohio, where I focus on hip and knee replacements. And today I'll talk a little bit about some common knee injuries that we see in athletes in sports. So first I'll get into ACL injuries. One of the more significant knee injuries that we see, the ACL, or the anterior cruciate ligament, is one of the most common ligaments that provides stability to the knee. Located in the front of the knee, it connects the lateral or the outside part of the knee of the femur to the front of the tibia. And it is important for the athlete when they're performing any cutting or twisting motions during sport. Therefore, we see these injuries happen in sports that have more cutting or twisting motions. So football, basketball, soccer, things like that. An athlete is most at risk of injuring their ACL when they're turning or twisting on a planted foot. So if that foot gets stuck on a turf or trapped on the ground from another player pinning it into place, it greatly increases the force through the ACL and can increase the risk of that ACL tearing. These can also be seen commonly as non-contact injuries. So if you ever noticed a knee of an athlete kind of buckle inwards in the position, that's the position the knee falls when the ACL tears. These are more common in female athletes. Women have a wider pelvis, so it increases the angle of force that is translated through the knee and puts more stress on the ACL during these cutting and twisting motions. Females also have a more narrow femoral notch. So if you can see this little notch where the ACL lives right here on this picture over there, that is a little bit more narrow in women, increases the risk of them injuring the ACL. Not all ACL injuries result in a complete tear. They can be sprained, remain intact. And if that's the case, they don't always require surgery. But an ACL tear does have a very, very low chance of healing on its own, and in that case, often requires surgery. So symptoms for these, people generally feel or hear a large pop when an ACL is torn at the time of the injury. And it's associated with immediate instability, pain, difficulty weight bearing, and significant swelling. So that's a big red flag. If you ever notice significant swelling right after the injury, that would be a concern for an ACL tear. And the best next step to do is to get an MRI to confirm the injury. From the surgical side of things, there are a variety of ways a surgeon can reconstruct the ACL, either with the patient's own patellar tendon, quadriceps tendon, hamstring tendon. Choice of graft really depends on the surgeon and their experience with different ways of harvesting that tendon. You can also use allograft cadaver tissue, but that's really only used in older patients, 40, 50 or up, because there have been some evidence that has shown there's a higher re-tear rate in those patients, in younger patients when an allograft tendon is used. The decision to perform surgery on this injury is based more on the patient as opposed to the injury. You can still perform inline movements with an ACL tear. So you can still jog, go up and down stairs. People living their day-to-day lives wouldn't necessarily notice not having an ACL. But any cutting, any twisting or turning, anyone trying to get back to their sport essentially needs a surgery for this. So the only people who could potentially get by without needing surgery is older recreational athletes, and that kind of is the reason to hang it up. However, I will say a chronic ACL deficient knee will have inherently less stability and can buckle easier than one with an ACL, and it increases your risk of other knee injuries such as meniscus tears or progression to arthritis. And so in younger athletes, continuing to play on this without getting a surgery really increases the risk of further injuring the knee. The last point I'll make is that physical therapy is very important pre and post-operatively for these patients. If we don't work, we work on getting full range of motion in the knee prior to an ACL reconstruction. The associated swelling in the knee from the injury decreases your ability to fully flex and extend your knee. If you don't get that corrected prior to the surgery, you can end up getting a stiff knee after surgery, which in and of itself is a problem. So we generally work with physical therapy to get you fully flexing and extending your knee prior to the surgery. And then there's a very important post-op protocol working with physical therapy to get you back to full strength and full motion after this reconstruction, which generally takes around 9 months, although it is patient dependent. Second injury I'll discuss is a meniscus tear, probably one of the more common injuries that we see in the knee. So each knee contains 2 menisci, one on the medial or the inside part of the knee, one on the lateral or the outside part of the knee. They consist of fibroelastic cartilage, but they essentially function as shock absorbers. So during activity, during exercise, the knee can experience 6 to 8 times, sometimes more, the force of your body weight through the knee. So the meniscus helps to disperse these forces. While it is important in stability, it's not as important as the ACL, but it does function as a secondary stabilizer to provide some stability to the knee as well. The menisci do not have a great blood supply, and the closer you get to the inner border of the meniscus, the worse the blood supply gets, which essentially means they have a poor healing potential and they're not necessarily going to heal on their own if we don't correct it with a surgical procedure. There's a couple different ways to classify meniscus injuries. Degenerative meniscus injuries aren't necessarily associated with sport. It's something that happens in older people and are wear and tear injuries over time. The acute meniscus injuries are the ones more commonly seen in athletes when there's a single moment in time when an athlete notices an injury after a fall or a twist. So those we define as acute. They also are classified based on the type of tear that occurs. So you can see that image up on the top right portion of the screen, looking at different types of tears. They can be associated with what we refer to as mechanical symptoms. So popping, clicking, catching. The type of tear that happens will determine the best course of treatment moving forward, as some of these tears are handled differently during surgery. So, for example, there's a specific type of tear, the one you can see in the middle on the bottom there called a bucket handle meniscus tear, where the displaced cuff of meniscus can actually displaces into the middle of the knee and physically prevents full extension of the knee because it gets mechanically interlocked in the notch and prevents you from fully extending the knee. So in that case, surgery is always indicated in order to get you moving again. Not all meniscus tears require surgery, but in a young athlete with an acute injury experiencing these mechanical symptoms, that is one that should go to surgery to get it checked out. Whether or not you're repairing it or just cleaning it up, again, the type of tear will determine what the best case moving forward in the surgery is. But without even going in and cleaning it up, sometimes those injuries can extend and become a bigger problem than they need to be. Generally, after a repair where you're putting a suture anchor or some type of fixation device through a meniscus injury, most surgeons will limit weight bearing for about 6 weeks after surgery, and return to sport isn't for about 4 to 6 months. Third injury I'll discuss is the MCL. So the MCL is the medial collateral ligament located on the inside or the medial side of the knee. Another commonly injured structure, actually probably the most injured ligament in the knee in athletes. It provides side-to-side stability. So it's at risk for being injured when a lateral force or direct force to the outside of the knee is applied on a leg whose foot is planted in the ground. And that's the reason why you see so many offensive linemen wearing knee braces, because they serve as a protective measure to protect their knees if they were to get rolled up on the side of the knee during a game. This knee is associated with pain on the medial or inside portion of the knee and instability with side-to-side motion of the knee. More common in males, when the MCL is torn, it usually occurs at the attachment to the femur, so at this top portion up here, as opposed to its attachment onto the tibia. And the only reason why I mention that is because when you have an injury to the MCL off of its femoral origin, there's a lower chance that you're going to need to undergo surgery from an issue like that, as opposed to when it gets torn off at the tibia. Again, most of these are treated non-operatively, so it's rare that you're going to operate on something like this. Usually you just give it 2 to 4 weeks of rest, depending on the severity of the injury, along with a hinged knee brace to provide some support while the injured tissue scars in. For more severe injuries, an MRI can be warranted. So here's an example of one of those MRIs, and you can see right about here is that disruption of that black band on the medial side of the knee, which is representing the MCL. Again, not common to require surgery for this injury, but if there is a complete tear with continued significant instability, sometimes a repair or a reconstruction is required. And last, I'll talk about one insidious injury. So IT band syndrome, a bit more chronic as opposed to the previous 3 that I talked about. The IT band is a fibrous band of fascia located over the lateral side of the knee. So you can see that issue right here. It is actually an extension of a muscle on the lateral side of the thigh that extends up past the outside of the hip. And the issue with the IT band is located over a little bony prominence on the outside of the femur called the lateral epicondyle. And so as you flex and extend your knee, the IT band snaps back and forth over that little bump, which can cause inflammation and swelling of the tissue. And when the tissue swells, it's going to become more of a problem as it continues to snap back and forth over this with any type of flexion and extension. So this causes inflammation and then irritation and pain with activity. So it ends up getting worse with people that are trying to work through it without appropriately addressing it. More often seen in runners and cyclists because they're athletes that are continually, repetitively flexing and extending the leg. So risk factors for this syndrome can be athletes who have a tight IT band at baseline or pain, people that suddenly increase their activity level or training intensity as opposed to gradually building it up over a period of time. Generally, these are also treated non-operatively. It is rare to have to operate on something like this. First line of therapy is to rest, and the hard part is to rest long enough to get this to calm down. This is similar to a lateral epicondylitis of the elbow, anti-inflammatories, and activity modification. So not common to have to do surgery for this. Therapy is a strong part of the treatment strategy for this. Specifically, exercises working on abductor muscles of the hip, such as clamshell exercises or side leg lifts, which can help recovery. Usually takes about 4 to 8 weeks to resolve, but it can persist for months. So if it is something that is still bothering you after 4 to 8 weeks, sometimes a steroid injection can be beneficial to be a local anti-inflammatory right over the spot where it's bothering you the most. So it continue to be aggravated by continued activity if not addressed. In rare refractory cases, you can operate on this either by excising a small portion of the IT band or lengthening it to decrease tension and decrease the amount of friction that area and that band is having over that bony protuberance, but not common. Thank you very much. And I think we're moving on to the question session.
Thank you, Dr. Erb. Yes, please place your questions in the Q&A box at the bottom of your screen. Go to our first question. Our first question of the evening is, with overuse elbow injuries, what is the protocol for using ice and heat?
In general, whatever feels good is the thing to do. For an acute injury, I always recommend using ice, 20 minutes on, 40 minutes off until the swelling goes down. Heat in general, if you're injured, but you're getting, it's feeling better, you're getting ready to play. Heat in general is good for like prior to playing the sport. It can help kind of warm you up.
Thank you. Can chronic IT band syndrome create misalignment of the knee?
The short answer is no. Sometimes misalignment of the knee can cause IT band syndrome, but it's not the other way around. And sometimes if you can have a a quadriceps muscle that is significantly stronger than a hamstring, that can also lead to IT band syndrome. But that is not something that is going to create a malalignment issue. That is something that happens at baseline prior to having IT band syndrome.
Thank you. Our next question is, how can I tell if my shoulder is sprained or torn?
Yeah, so a sprain can be essentially a low-grade tear of the rotator cuff, but we're talking about a true rotator cuff tear, typically on examination. You'll see weakness, and usually that has to be evaluated by your orthopedic surgeon. And usually we will, if we have high suspicion of a rotator cuff tear, confirm that with an MRI. Alternative to that, you can do dynamic ultrasound, but typically in my practice, we'll order an MRI to confirm whether or not someone has a rotator cuff tear.
Thank you. What are some exercises to strengthen my hip after an injury?
So the hip is complex. There's different muscle groups, but the general philosophy depends somewhat on the type of injury. But you want to focus on improving some of the flexibility of that muscle group, so stretching it out, as well as focusing on stretching the hamstrings out in the back and the core strengthening, because they all play a big part in the mechanics of your hip. So the core is often neglected in recovering from a hip injury, but it can play an important part in the recovery process.
What should I do immediately after injuring my elbow? And are there elbow braces effective for injuries or pain?
I mean, if you injure your elbow and it's hurting you enough that you're thinking about this question, you should probably go get it checked out. If you have an orthopedic provider close by, that's the best bet. But otherwise, I would see your primary care doctor. If those aren't available, in general, rest it, use some ice, take some anti-inflammatories, see if you get better a little bit.
Do you use BPC 157 peptide amino acids, either oral or injectable, for healing process for muscular injuries?
No,
I do
definitely do
not.
not.
No.
No.
And what is the ratio of strength of quadriceps to hamstrings, referring to the IT band syndrome?
Usually the hamstrings are weaker than the quadriceps. And so I don't have a number for you referring to what that is, but a lot of times if the quad overpowers the hamstring, it can kind of alter the kinematic chain of the lower extremity. So the goal is usually to try and get those to be a little bit similar or comparative to each other, as opposed to having one being stronger than the other.
Rehab for IT band syndrome. Is it better to prioritize flexibility, mobility, or strength and cross training to prevent IT band syndrome for runners or sprinters?
Good question. Initially, I would work on prioritizing flexibility and mobility, but the goal when you want to focus on strength is to focus on the appropriate muscles to strengthen. So I talked about that IT band coming up and over the hip. The hip abductors are the ones that really can control the type of exercises that you can do that can benefit you. So, anything that's working the side muscles of your butt, those things are the ones that are going to help you with the rehab from an injury like this, as opposed to focusing on, squats, quadriceps, hamstrings, something that's not going to benefit you as well.
What imaging tests are commonly used to diagnose shoulder injuries?
Yeah, so typically I'll start with an X-ray, so plain radiographs of the shoulder, and that'll tell me if there's any issues with the bone, if there's any changes that appear to be degenerative in nature, like arthritis. It can diagnose acromioclavicular joint injuries, also known as shoulder separation, fractures, dislocation. So the first line imaging is a plain X-ray. And then, as we were discussing before, to better evaluate the soft tissues in concerns for a rotator cuff injury or a labral injury, or any of the soft tissues that we can't see on an X-ray, I'll typically order an MRI. So that's the second line treatment. Alternative modalities are ultrasound. Some seasoned practitioners who use a lot of ultrasound for diagnostic purposes can diagnose a wide range of shoulder pathology on a dynamic ultrasound. In my practice, I do not utilize this, but that is an alternative method. And those patients who can't get MRIs due to a pacemaker or some other contraindication, you can do a CT arthrogram, which is injecting contrast dye into the shoulder joint, and then doing a CAT scan, which is not quite as sensitive as an MRI would be for diagnosing shoulder pathology, but is a close second in that regard.
Are any of you aware of current research on the outcomes with PRP injections, and typically how many injections are used?
I think there's an evolving amount of literature coming out about PRP for different areas of the body. Some of it has been studied better than others. In particular, lateral epicondylitis is one of the strongest evidence behind PRP as far as improvements go. It's been studied somewhat heavily within knee in the mild arthritic knee setting. So one of the issues is it's a lot of out-of-pocket costs because insurance providers haven't caught up to some of the current literature coming out. So hopefully over in the coming years here, hopefully more insurance companies will buy into the evolving amount of literature coming out about its benefit.
And are you seeing good results with PRP treatments? What is the time frame of getting noticeable results?
The simple answer is it's somewhat variable of a response from patient to patient, but in general, it can take a few weeks or so for the onset of relief to occur, and then it can last for months, hopefully, and sometimes eliminate the inflammatory cascade to the point that you're not relying on it anymore.
Sports injuries typically involve the adductors. If a hip joint injury is ruled out, how do you work the adductors if they still are painful, especially if it's already been 4 to 5 months of relative rest?
So it would take a little bit of an evaluation by a specialized orthopedic surgeon to determine, if it really is the adductors or if it's something deeper within the hip, because it is a complex joint. But let's say it is just the adductors and they're just not improving. One thing you could consider is an injection around that area. And that can be both hopefully therapeutic in the sense it gives you relief, but also diagnostic in the sense that if you do get relief, we know that that's the issue. So that may be the next step in the process of that chain. And then from there, it depends on how the recovery goes.
And that was our final question. Any additional questions? Thank you very much to our physician presenters. We appreciate your time. And thank you for joining us for tonight's webinar. The final webinar in our series on sports medicine will be held on Wednesday, October 16th from 7 to 8 p.m. Doctors Roberto Brandau, George Maddock, and Mark Mendezun will be speaking on sports-related injuries of the foot, ankle, and knee. You can register for our upcoming webinars at orthoalliance.com/events. Thank you and good night.